The next section that we're going to cover in some detail is a very important one in terms of clinical neurology, and this is, in Chapter 5, the brainstem. Certainly, the brainstem is going to be the home of most of the cranial nerves, so this is where we'll deal with their detailed clinical anatomy. Fundamentally, the brainstem is divisible into three parts. They are the midbrain, the pons, and overlying the pons will be the cerebellum, which we'll talk about later, and the medulla. The midbrain basically begins just below the diencephalon. It's its own brain vesicle. The pons is in the middle, as we said, is overlain by the cerebellum. The medulla is the most caudal portion of the brainstem, and it's continuous with the spinal cord. As we said, the brainstem is important for a variety of reasons, the major one of which is it is the home of the nuclei, the sites of termination or origin of the fibers of 9 out of the 12 cranial nerves. The only cranial nerves that are not brainstem cranial nerves will be cranial nerves 1, the olfactory, 2, the optic nerve, and cranial nerve 11, the accessory, which is really a misplaced cervical spinal nerve because its motor fibers arise from cervical spinal cord. Then here is the organization, which we'll then look at a diagram of. And it's important to recognize what parts of the brainstem are giving rise to which cranial nerves. For example, and there's going to be a linear organization to this, as we will see. 2 of the cranial nerves, cranial nerve 3, the oculomotor, and cranial nerve 4, the trochlear nerve, arise from different parts of the midbrain. 4 cranial nerves, trigeminal, abducens, facial, and vestibulocochlear, cranial nerves 5, 6, 7, and 8, basically enter or exit from various parts of the pons. The last 3 brainstem cranial nerves, the glossopharyngeal, vagus, and hypoglossal, are the medulla cranial nerves. And as we've already indicated, the fibers of the accessory nerve, even though it is cranial nerve 11 because it exits through a hole in the skull, is really a misplaced cervical spinal nerve arising from cervical spinal cord. One of the more important points that we will add to this is not only is it important to recognize which cranial nerves arise from various parts of the brainstem, but, as we note down at the bottom of the slide, note that the purely motor cranial nerves 3, 4, 6, and 12, exit from the medial aspect of the brainstem, whereas the mixed cranial nerves exit or enter from the lateral parts of the brainstem. And this is important because most of the commonly caused brainstem lesions are vascular insults. And as we'll see, we will divide those vascular syndromes into either lateral vascular syndromes that will typically involve a mixed cranial nerve or medial vascular syndromes involving the brainstem, which would involve a purely motor cranial nerve that's exiting close to the ventral midline. So with that organizational basis, let's now look at 2 views of the brainstem. A dorsal view is on the left side of the screen, a ventral view on the right side. And note again that not only is the brainstem home to the cranial nerves, but virtually all of the cranial nerves are exiting from the ventral or ventrolateral aspect of the brainstem. Only the trochlear nerve arises from the dorsal aspect of the brainstem in the area just posterior or below the inferior colliculi. All right, before we document the more detail about the cranial nerves, let's look at the gross anatomy of the brainstem because it's not uncommon to see cadaver views of a brainstem on test questions. First off, note that the midbrain is characterized on its dorsal surface by 2 pairs of colliculi. There's a pair of superior colliculi and a pair of inferior colliculi. So what we're going to see is virtually any section that basically is run through the midbrain must have either the superior or the inferior colliculi on its dorsal surface. And that's going to be a very good landmark because it's not uncommon for exam questions to show unlabeled brainstem sections and assume that you know where you are, whether you're in the midbrain, the pons, or the medulla. So note that the superior colliculi functionally are visually related structures. They help coordinate vertical conjugate gaze, and an area just in front of the superior colliculi that's known as the pretectal area. The tectum means roof. The pretectal area contains neurons that link the light reflex together, joining optic nerve axons with oculomotor axons. And as we'll see a little later, note the relatively close relationship of the pineal gland or pineal body, and note how it is suspended just above the point where the superior colliculi are, because as we'll see a little later, we'll talk about a patient that develops Parinaud syndrome, which is typically the result of a pineal tumor that compresses the area of the superior colliculi and alters vertical conjugate gaze, as well as suppresses the pupillary light reflex, as illustrated here. Then, just below the superior colliculi are a pair of inferior colliculi. They are auditory structures. They're helping process sound basically by linking the olivary nuclei with the area of the thalamus in the medial geniculate region. So they are auditory structures, whereas the superior colliculi are visual structures. And certainly they dominate the dorsal aspect of the midbrain. And as we said, exiting just inferior to the inferior colliculi is the only completely crossed cranial nerve, and this is the trochlear nerve, whose fibers you see emanating from the velum just below the inferior colliculi and sweeping around to the ventral aspect of the brainstem, where they will join up with cranial nerves 3 and 6 to pass through the superior orbital fissure and enter the orbit. On the ventral aspect of the midbrain, you can see that it is dominated by a pair of massive fiber bundles, each of which is known as a cerebral peduncle, a foot of the cerebrum. In each cerebral peduncle are some old friends from spinal cord anatomy. Running through the middle of each cerebral peduncle are the axons that make up the corticospinal or pyramidal tracts. And we'll talk about their course in a moment. I just wanted to note that that's their major claim to fame. Note that separating the pair of cerebral peduncles is an interpeduncular fossa, and basically emanating out of this fossa are the fibers of the oculomotor nerves, as illustrated here. And note that the interpeduncular fossa is just inferior or below the mammillary bodies, which are the most grossly visible part of the diencephalon. Then, the pons. The dorsal aspect of the pons is separated from the overlying cerebellum by the rhomboid-shaped fourth ventricle. So in the dorsal view on the left side of the screen, we show the cerebellum as being cut away, and what's shown here are, on each side, the 3 cut surfaces of the cerebellar peduncles, not to be confused with the cerebral peduncles. And through these cerebellar peduncles are all of the axons that are entering or exiting a cerebellar hemisphere on a corresponding side. So, point is, all pons sections are going to have the cerebellum above them, and all pons sections are also going to have the fourth ventricle separating the overlying cerebellum from the dorsal surface of the pons. The ventral surface of the pons on the right is characterized by a dramatic ventral bulge, and you can see how dramatic it is and how different its appearance is grossly from the form of the cerebral peduncles above it. Now, the brainstem cranial nerves that arise from the pons, as we indicated earlier, are 5, 6, 7, and 8. But we need to make a very important distinction. Note that cranial nerve 5, which is the largest of the cranial nerves, is really the only true pontine cranial nerve, because its fibers, as you see here, are actually entering or exiting from the rostral and lateral portion of the pons itself. In contrast, even though we call them pontine cranial nerves 6, 7, and 8 are exiting right at the pontomedullary junction. And logically, the purely motor cranial nerve of those 3 is 6, exiting closest to the ventral midline. Then as you move laterally, we get the motor and the sensory fibers of the facial nerve, and then most laterally at the pontomedullary junction, in what's also known as the cerebellopontine angle, are the entering fibers of the vestibulocochlear, or the 8th nerve. So the point is, we can have various pontine lesions. For example, a lesion in the rostral pons will affect the fibers of the trigeminal nerve only, whereas a lesion in the caudal pons might affect cranial nerves 6 and 7 or 7 and 8 because those three cranial nerves are exiting basically or entering at the same point. The medulla, last portion of the brainstem, is the home of cranial nerves 9, 10, and 12, all exiting ventrally or ventrolaterally. And before we look at those, let's go back to the dorsal aspect of the medulla, because on the dorsal aspect of the medulla are the upward continuations of the dorsal columns that we discussed at spinal cord levels. Each dorsal column, the fasciculus gracilis and the fasciculus cuneatus, is cruising up from the dorsal aspect of the spinal cord, and their goal is to reach and synapse in a corresponding dorsal column nucleus, both of which are illustrated on the diagram on the dorsal side on the left. The more medial of the dorsal column nuclei is certainly going to be the nucleus gracilis. The more lateral of the dorsal column nuclei is the nucleus cuneatus. So that's the claim to fame of the dorsal aspect of the medulla. The ventral aspect of the medulla has the cranial nerves that are exiting from it, but also the ventral midline of the medulla is marked by a pair of what are known as medullary pyramids, but recognize that a pyramid, as we've indicated earlier and show down in parentheses, is a synonym for the corticospinal tract. Then, exiting just lateral to each medullary pyramid are the motor fibers of the hypoglossal nerve, and then separated from the hypoglossal nerve and above it will be the olive. And on the other side of the olive, which will be seen a little more easily in medullary sections, are the entering or exiting fibers of cranial nerves 9 and 10. So again, looking at the organization, you can visualize, again, the point we made earlier, how cranial nerves 3, the oculomotor, 6, the abducens, and 12, being purely motor cranial nerves, are exiting very close to the ventral midline of the brainstem, whereas the mixed cranial nerves 5, 7, 9, and 10 have a much more lateral entry or exit position based on the fact that these are mixed cranial nerves. And then certainly most laterally will be the entering fibers of the vestibulocochlear nerve that's entering the lateral aspect of the medulla pons junction in the cerebellopontine angle. And then finally, last point we need to make about this slide is the lower medulla is not really a home of cranial nerves. It's much more important because it's the location where two of our fundamental neural systems have axons that cross the midline. As indicated here, this will be the crossing point of the fibers coming out of the dorsal column nuclei, which will form the medial lemniscus, which will ascend through the brainstem. But also just below that will be the site where the corticospinal or pyramidal tracts are crossing the midline, as illustrated on the picture on the right, on their way down to serve lower motor neurons at all spinal cord levels. Now that we've covered where various cranial nerves enter or exit from the brainstem, we need to review their normal anatomy, functions, and their clinical neurology in the presence of lesions. So a couple of points are relevant to the anatomy of cranial nerves. Certainly, it's most important to recognize what the normal functions of cranial nerves are. Second, and important related to that, is how you test cranial nerves. And one of the things that's going to be buried in this chart will be a series of cranial nerves that are linked together in one of 3 cranial nerve reflexes. So we're going to talk about the anatomy of and the clinical neurology of the light reflex, the blink reflex, and the gag reflex, each of which contain a pair of cranial nerves, one sensory, one motor. But the unique feature about cranial nerve reflexes, which is very valuable to their testing, is in each of those reflexes, when you stimulate the sensory fibers of a corresponding cranial nerve, the motor response that will be generated under normal conditions will be a bilateral one. Meaning that, as we'll see, when we talk about the light reflex, we're going to stimulate one optic nerve, and that's going to bilaterally result in a reflex stimulus of both oculomotor nerves, one on the side of the stimulus that'll produce a direct response, and one on the non-stimulated side, which will produce a consensual response. So that's true of the light reflex, that's 2 and 3. The blink reflex will also produce a bilateral motor response, by stimulating sensory fibers of 5 with a corneal stimulus. That will produce a bilateral blink because you're activating both facial nerves simultaneously. And then the gag reflex will also be useful. That is a reflex that involves the sensory fibers of 9 and the bilateral stimulation of motor fibers of both vagus nerves. Next, and certainly first and foremost, will be what kind of clinical anatomy is generated when you have a specific cranial nerve lesion. So first, we could deal with the olfactory nerve in a straightforward fashion. We'll see this a little later when we talk about the limbic system, but at least for cranial nerve purposes, it is a purely sensory cranial nerve. The olfactory nerve filaments enter the anterior cranial fossa after passing through the cribriform plate, and they're obviously associated with the sense of smell. So when you lose or have an olfactory lesion, typically caused by a cribriform plate fracture, among others, patients develop anosmia or dysosmia, depending on the extent of the damage. The optic nerve will be a topic of a whole hour of conversation dealing with the anopsias, but at least for today, let's recognize that the optic nerve is certainly a nerve that's associated with visual input. And as we pointed out when we developed the brain, it is the only nerve that basically is myelinated in its entirety by oligodendrocytes. So in reality, it's not really a nerve at all. It is a tract of the brain, unlike any other cranial and spinal nerve. And as a result, as we point out on the chart, it's going to be the only cranial or spinal nerve that's going to be affected by a central nervous system demyelinating disease. A common would certainly be multiple sclerosis. So we'll deal with visual field deficits at another time, but they will be or give rise to forms of anopsias. So really our emphasis for today in terms of the optic nerve is it is the sensory limb of our first cranial nerve reflex, is the light reflex. As we indicated, you test this by shining light in a patient's eye, and under normal circumstances, in response to that sensory stimulus, both pupils should constrict simultaneously because you are linking the optic nerve axons in the pretectal area with the parasympathetic axons of both cranial nerve 3s. Next, when we look at the cranial nerves that are associated with ocular movements, these involve cranial nerves 3, 4, and 6. And a lot of detailed clinical anatomy is associated with these because these are very common sites of lesions. For example, the ocular motor nerve is one of these 3 purely motor nerves, and the ocular motor nerve basically innervates 4 muscles that move the eyeball. They are the superior rectus, the inferior rectus, the medial rectus, and the inferior oblique. So arguably, the action sum total of these muscles can allow you to move your eyeball in almost any position. But these innervated muscles, the most important action arguably is adduction, pulling the eyeball toward the nose. And this certainly makes the medial rectus muscle arguably the most important muscle associated with that action. Next, the other skeletal muscle that's innervated by oculomotor nerve fibers is the levator palpebrae superioris. But recognize that the levator palpebrae superioris is not just skeletal motor fibers that are innervated by the oculomotor nerve. It also contains smooth muscle that's under sympathetic control. So when there is a levator palpebrae superioris weakness that results in atosis, the ptosis can be the result of an oculomotor nerve lesion, or it can be the result of a sympathetic lesion whereby the ptosis is one of the signs or symptoms associated with Horner syndrome. Then, the oculomotor nerve is one of the cranial nerves, one of 4 cranial nerves, that carries parasympathetic axons. And these parasympathetic cranial nerves are cranial nerves 3, 7, 9, and 10. The parasympathetic functions of the oculomotor nerve are exclusively to innervate 2 smooth muscles in the orbit. One of them is the constrictor of the pupil, or the sphincter of the pupil, and the other is the ciliary muscle that allows the lens to round up during accommodation or the near response. So, complicated motor actions associated with the oculomotor nerve, and obviously the innervation of structures of the oculomotor is much more extensive than the single muscles, as we'll see, innervated by cranial nerves 4 or 6. Then, Lesions associated with the oculomotor nerve. Lesion of any ocular nerve is going to result in blurred or double vision because you'll lose the ability to move eyeballs in a conjugate fashion. But because the most important action of oculomotor nerve innervated muscles is adduction, patients typically present with a loss of adduction, and as a result, the antagonist muscles take over, in this case, the abduction component of the lateral rectus innervated by cranial nerve 6, and tends to pull the eye laterally, a condition that results in an external or a lateral strabismus. So that's a classic presenting sign of a patient with an oculomotor nerve lesion. And certainly that's going to affect the patient's ability to gaze in a horizontal or parallel fashion because you eliminate the patient's ability to adduct an eye at all on the corresponding side. Then certainly, as we've indicated, when you have a lesion of the skeletal motor fibers of the oculomotor nerve, the patient will present with a ptosis, drooping of the eyelid. And then if the lesion is a complete one, the patient will tend to also present with the parasympathetic signs, where you'll lose the ability to constrict the pupil, so the pupil will be dilated on the corresponding side. There will be a loss of the motor limb of the light reflex on a corresponding side. And as a result of ciliary muscle weakness, the patient will lose their so-called near response. They will be unable to change the shape of their lens in response to change in the depth of field of an object that they're looking at. One other important point to be made about the oculomotor nerve is that the parasympathetic axons run on the outside of the optic nerve. So if there is an external compression of the oculomotor nerve, it will tend to result first in the parasympathetic signs and later on result in the skeletal motor signs because of the location of the different functional fibers. Then let's now look at the trochlear nerve. It looks fairly simple in what it does because, as we know, the trochlear nerve innervates a single skeletal muscle that acts on the eyeball, and this is the superior oblique. And this is where some confusion generally arises, so we'll go through this relatively slowly. Notice we say on the PowerPoint slide that there are three functions of the superior oblique muscle, three actions on the eyeball that are generated when the superior oblique muscle contracts. The major one, that basically, which is the testable one, as we'll see, is the superior oblique is a major depressor of the eyeball. It enables you to look down. But in addition, the superior oblique is a weak abductor of the eyeball, weak because the lateral rectus innervated by cranial nerve 6 is a much more powerful one. And third, the superior oblique allows you to intort the eye. That is defined as your ability to take the 12 o'clock position of the eyeball and rotate that 12 o'clock position toward the nose. That's described as being intorsion. And certainly you don't do in an intorsion and extorsion voluntarily. You do it reflexively when you tilt your head either to the right or the left, and it causes your eyes to roll, one extorting and the other intorting in a reflex response to head tilt. But here's the other point. We say certainly that the superior oblique is a muscle which depresses the eyeball. So one of the key elements that comes up is how do you test the superior oblique as a depressor of the eyeball? The point being that when you look straight ahead and you look down from the neutral position, you are utilizing two muscles to depress the eyeball. One is the superior oblique, innervated by the trochlear nerve. The other is the inferior rectus, which is innervated by the oculomotor nerve. So the point is, when you look straight ahead from the neutral position, you're utilizing both muscles innervated by two different cranial nerves with equal power. So to isolate and test just the superior oblique as a depressor using the so-called H in space test, you would ask a patient to adduct their eye first and depress their eye from the adducted position, because then the only way you can depress your eye from the adducted position is using the superior oblique muscle. Whereas if you wanted to test just the inferior rectus as a depressor of the eye, you would ask the patient first to abduct their eyeball and then look down from the abducted position as an additional test of third nerve function. So that's the point. When we look over on the lesion side, when will a patient have diplopia when they have a trochlear nerve lesion? they will have diplopia on downward gaze when they are attempting to depress the eye from the adducted position. So as a result, when you use the adducted position and depressing from the adducted position, when you are converging on a stimulus that's directly in front of you, particularly the diplopia will be most manifest when you're going downstairs or reading. Both conditions you have converged both eyes, and you're depressing the eyes from the adducted position using the superior oblique muscles. So that's the important point to be made, is that one of the actions of the superior oblique is to serve as a weak abductor of the eyeball, but that's not to be confused with the test position where you ask the patient to adduct their eye first using cranial nerve 3 and the medial rectus, and asking the patient to depress their eye from the adducted position. And again, as we've already indicated, the intorsion component may also be an important element, because particularly when the patient is looking straight ahead, when you have a trochlear nerve lesion, there will be a weakness of intorsion on the corresponding side, and as a result, the eye on the corresponding side will be extorted. So in order to counteract the diplopia, the patient will typically tilt their head away from the lesion to intort the normal eye, basically to eliminate the intorsion loss and the diplopia associated with the nerve lesion. Now let's look at the last of the 3 cranial nerves that innervates muscles that move the eyeball, and this is the most straightforward of all 3. This is cranial nerve 6, the abducens. Basically, its motor fibers innervate one muscle, the lateral rectus, that does one thing very well. It is the best abductor of the eye. So in patients that develop an abducens nerve lesion, they're going to have diplopia, as we saw in all of the other ocular lesions, but the diplopia will typically be associated with an internal or a medial strabismus because of the loss of the abduction component, as opposed to the lateral or the external strabismus we saw in a patient with a third nerve lesion. So again, patients, when they have diplopia, will either tilt their head, change head position to eliminate the diplopia as a result of this particular lesion. And again, the lateral gaze will be affected. In this patient, horizontal gaze. And typically, this patient, if they don't tilt their head, they may squint, producing what's known as a pseudotosis, to try to eliminate the diplopia on the side of the abducens nerve lesion. Next, let's look at cranial nerve 5. It's the largest of the cranial nerves, as we illustrated earlier, and it's the first of our mixed cranial nerves that we'll discuss. And basically, as we know from gross anatomy, the trigeminal nerve is subdivided into 3 divisions that contain approximately the same number of axons. They are known as the ophthalmic division, the maxillary division, and the mandibular division. And what each of these 3 divisions carry are fibers that are termed fibers of general sensation. Because in a way, the trigeminal nerve is really an example of a very large spinal nerve, in that its sensory fibers are conveying the modalities of touch, all of the discriminative touch modalities, sensations of pain, as well as temperature sensations from various parts of the face, the scalp, the oral cavity, the nasal cavity, as well. For example, in terms of strict distribution, the ophthalmic division serves skin of the forehead, skin basically of the anterior scalp, skin of the skin of the dorsum of the nose, as well as the surface of the cornea. And it is those corneal sensory fibers which are important because they will provide the sensory limb of our second cranial nerve reflexes, and this will be the blink reflex, where a corneal stimulus that activates the ophthalmic division of 5 will result in a bilateral blink or eye closure that results from bilateral activation of the motor fibers of each facial nerve. Then the maxillary division also conveys fibers of general sensation, touch, pain, and temperature, and this is the major sensory component of the fifth nerve that serves virtually all of the nasal cavity, as well as the superior part of the oral cavity, surface of both the hard and the soft palate, and also innervates the maxillary teeth, as well as the skin over the maxilla on the outside of the face as well. And then finally, the sensory fibers of 5-3, the mandibular division, are associated with mandibular face and mandibular teeth. They serve, in addition, the inferior aspect of the oral cavity, including the anterior 2/3 of the tongue for general sensation. And then finally, we know that the trigeminal nerve is a mixed nerve, but as in the case of many cranial nerve branches, the fibers of the trigeminal, the branches of the trigeminal are not all mixed because only the mandibular division is accompanied by motor fibers. And as we see on the next slide, those motor fibers that are associated with the trigeminal nerve are serving the muscles of mastication. And the four major muscles of mastication are temporalis, masseter, the medial, and the lateral pterygoids. And certainly a major action of 3 out of the 4, temporalis, masseter, and medial pterygoid, is to elevate the mandible. The lateral pterygoids are going to be important, as we'll see in a minute, because they contract to protrude the mandible, which is a necessary action which is generated at the initiation of mouth opening. Then, the other muscles innervated by the trigeminal nerve, we kind of blame embryology for this, are associated with the first pharyngeal arch, and they also include additional muscles which attach to and depress the mandible, including the anterior belly of the digastric and the mylohyoid muscle. And they're also associated with 2 muscles that have nothing to do with mandibular movement, but are associated with the ossicles in the middle ear, the tensor tympani, which is attached to the handle of the malleus, and the tensor pallati muscle, which is it obviously plays a role in tensing the soft palate during swallowing. So in terms of clinical anatomy, if we go back to the previous slide briefly, we know that a complete lesion of the trigeminal nerve will affect all of the general sensation of its various territories, including the forehead, scalp, cornea, obviously the oral and nasal cavities, as well as maxillary teeth, mandibular teeth, and the corresponding areas of the face for those kinds of sensations. If the patient has a lesion that also involves the mandibular root, they will also have a weakness of mastication problem because all the muscles that move the mandible are innervated by the trigeminal nerve. And note that certainly there's going to be a weakness of muscles of mastication on the corresponding side of the lesion, but when the patient protrudes their mandible, the jaw will tend to deviate toward the side of the lesion because of the unopposed action of a corresponding lateral pterygoid muscle. And note that of idiopathic origin might be a patient that develops trigeminal neuralgia or tic douloureux. This is the result of compression typically of either the maxillary or the mandibular divisions of 5, resulting in intractable pain in the various cutaneous or mucosal territories of those 2 nerves. Next, let's move to another very important cranial nerve in terms of clinical and functional anatomy, and this is the facial nerve, one of the more commonly lesioned cranial nerves. And again, it's a mixed cranial nerve. Its major motor action, as we know, is to innervate all the muscles of facial expression. These muscles act as sphincters and dilators of various openings on the face, allowing us to close an eye, basically wrinkle the forehead, change the shape of the position of the mouth, purse the lips, wrinkle the skin of the neck. And note that they're probably the most important muscle, one of the more important muscles innervated by facial nerve fibers that's not a muscle of facial expression is the stapedius muscle, which limits movements of the stapes in the middle ear reflexively. So those are major skeletal motor actions of the facial nerve. Facial nerve also is a cranial nerve that carries parasympathetics, lots of them. And the parasympathetics associated with the facial nerve are exclusively associated with the innervation of glands. They provide the parasympathetic innervation to the submandibular and the sublingual glands, and they also provide the parasympathetic innervation to glands in the oral and nasal cavity, mucus glands, and diagnostically the most important gland innervated by facial nerve parasympathetic axons is the lacrimal gland. So that's an additional motor component and an important one of the facial nerve, as we'll see. The sensory fibers of 5 do two very different things. There is a small area of skin behind the ear covering the mastoid process, as well as part of the skin of the external auditory meatus, and a little part of the external surface of the tympanic membrane that's served by sensory fibers of facial nerve. And the other important sensory component of the facial nerve carries taste from taste buds in the anterior 2/3 of the tongue, as well as taste buds that are situated on the soft palate. So in terms of clinical anatomy, a classic lesion of the facial nerve produces what is known as Bell's palsy. And that typically is the result of a lesion that occurs somewhere inside the temporal bone in the facial nerve. And typically a Bell's palsy patient is going to have weakness of muscles of facial expression on the side of the lesion that will present itself with an inability to wrinkle the forehead, an inability to close an eye on the side of the lesion, the corner of the mouth will droop, the patient will not be able to flare or change the position of their nostril, and they may also develop hyperacusis, a patient meaning that they will develop hypersensitivity to loud sounds because of the stapedius weakness as well. So typically, in any patient that has Bell's palsy, since these motor fibers that serve muscles of facial expression are the longest fibers, or the fibers with the longest course, typically a patient that develops a facial nerve lesion will virtually always have facial muscle weakness. Probably second in line is that same patient will tend to develop altered sensation, numbness, or even pain behind the ear because those cutaneous fibers have the same course length as the fibers that are serving muscles of facial expression. So typically those two motor and sensory signs are seen together. Then third in order, as we move back up along the length of the facial nerve, a patient will develop altered sensations of taste, a dys or an ageusia on a corresponding one half of the anterior 2/3 of the tongue. That'll be number 3. Symptom number 4 will be, depending as the lesion moves closer to the brainstem, the patient may develop hyperacusis because the stapedius muscle is affected. And then finally, the complete lesion of the facial nerve that includes the skeletal muscle problems, the pain and altered sensation behind the ear, the taste alteration. The final symptom that results in a complete lesion, from a complete lesion of the facial nerve, is a loss of lacrimation because those fibers branch off of the facial nerve closer to the brainstem, and that patient will present with a dry eye that will also tend to be irritated because the patient will not be able to close the eye on the side of that lesion. Next, let's deal with the normal and clinical anatomy of the 8th nerve. This is vestibulocochlear. And as the name implies, the 8th nerve is serving and innervating two very different kinds of receptor hair cells in the inner ear. Certainly the cochlear part of the 8th nerve is involved in hearing, and when there is a lesion of either the cochlear nerve or any neural component involving auditory processing, a patient will develop a sensory neural hearing loss. And when we deal with the anatomy of the auditory system in a little while, we'll compare a patient's sensory neural hearing loss with a different patient that has a middle or an external ear problem that will have a conductive hearing loss. The vestibular part of the 8th nerve innervates two different kinds of receptors. One set of hair cells that are innervated by the vestibular nerve fibers are sensing angular acceleration or head turning. And the other of the vestibular nerve fibers are innervating hair cells that are involved in linear acceleration, basically the linear pull of gravity toward the center of the earth. So typically when patients have a vestibular nerve lesion, they're going to have dizziness, nausea, vomiting, even balance problems. And if you lesion the fibers that are associated with angular acceleration, a patient might develop a vestibular evoked nystagmus that we'll wire up and discuss a little later. Finally, 9th nerve. 9th nerve is, like 5 and 7, one of the 4 mixed cranial nerves, but in terms of its clinical anatomy, it's very difficult to evaluate 9th nerve integrity based on what most of its fibers are serving. For example, it is a mixed nerve, but there's only a single skeletal muscle that is being innervated by the skeletal motor fibers of the glossopharyngeal nerve, and this is the stylopharyngeus muscle, which elevates the pharynx during swallowing but can't be tested in isolation. The other motor fibers of the ninth nerve are parasympathetics that innervate the parotid gland. And again, if there were a glossopharyngeal nerve lesion, it would be very difficult to evaluate a reduction in parotid gland output because we have all of the other salivary glands innervated by facial nerve bilaterally and also by the intact glossopharyngeal nerve contributing to the volume and content of saliva. So it's very difficult to evaluate a patient with a ninth nerve lesion in terms of its motor fiber problems. Fortunately, the glossopharyngeal nerve contains a number of mucosal sensory fibers in the range of your tongue depressor because the glossopharyngeal nerve provides all sensation or carries all of the sensations from the posterior one-third of the tongue, which is in the oropharynx, as well as the lateral walls of the oropharynx, particularly the mucosa covering each tonsillar fossa. So it is those oropharyngeal sensory fibers that are tested and evaluated in a patient by utilizing those sensory fibers in the sensory limb of our third reflex, and this is the gag reflex, meaning that when you stimulate the oropharyngeal mucosa by touching the oropharynx with a tongue depressor, there will be a bilateral activation of all of the skeletal motor fibers in the vagus nerves. And as we'll see when we talk about the vagus momentarily, in response to this oropharyngeal stimulus, the soft palate elevates, the larynx closes, and the pharynx elevates itself and generates a peristalsis because you have artificially stimulated the reflex or second stage of swallowing. So fundamentally, the only way really to evaluate ninth nerve integrity is to stimulate the oropharyngeal sensory fibers and see whether there is a bilateral motor response to that sensory stimulus that is the motor limb of the gag reflex. Last but not least, the ninth nerve is also providing the sensory innervation of the carotid body and the carotid sinus, presumably along with some visceral sensory fibers of the vagus nerve as well. Next, let's look at the vagus nerve because it's next, and we know that unlike 9, even though the vagus nerve is mixed, it innervates a lot of skeletal muscles, any weakness of which could be evident clinically. For example, without getting into any specifics, we say that the vagus nerve innervates virtually all of the muscles of the soft palate, except for the tensor, which is innervated by 5. It innervates all of the pharyngeal muscles except one, the exception being the stylopharyngeus, which we just discussed is being innervated by cranial nerve 9. And vagal motor fibers do innervate all of the muscles of the larynx. The major nerve that's serving this function is the recurrent laryngeal branch of each vagus nerve. So there are going to be lots of clinical signs and symptoms directly attributable to a vagus nerve lesion where there is an effect on the movements of the soft palate, the pharynx, and the larynx. For example, when there is soft palate weakness, the patient will have a decreased ability to elevate the palate during swallowing. They may have a droopy palate basically on the side of the vagus nerve lesion. Patients will tend to demonstrate nasal speech because you elevate your palate during the speech process. They might also exhibit nasal regurgitation of liquids because you're elevating your soft palate during swallowing to keep liquids from regurgitating back into the nasopharynx and into the nasal cavity. So, in addition, when there is palate droop associated with the vagus nerve lesion, the uvula will deviate away from the side of the lesion, unlike the jaw, which deviates toward the side of the lesion fifth nerve, and as we'll see, unlike the tongue, which will also deviate toward the side of the lesion hypoglossal nerve, which we'll see in a moment. If there is a weakness of the pharyngeal muscles, the patient will note or complain of a difficulty in swallowing or a dysphagia. And classic vagus nerve sign when the laryngeal muscles are affected is the patient will demonstrate hoarseness or hoarse speech as a result of an inability to ab or adduct the vocal cord on the corresponding side of the lesion. And again, as we already illustrated, the vagus nerve provides the motor limb, the bilateral motor limb of the gag reflex. when it's linked together with the sensory fibers of cranial nerve 9. Finally, the vagus nerve has lots of parasympathetics associated with it, but those parasympathetics are distributed mainly to the thoracic and much of the abdominal viscera, and typically, although the patients might exhibit some delayed gastric emptying, we use the skeletal muscle signs and symptoms as a more reliable indicator of vagus nerve lesions than the parasympathetic signs. And just a final note, certainly you are testing the gag reflex frequently to evaluate the sensory fibers of 9 and the motor fibers of 10, but basically there are sensory and motor fibers of the vagus nerve that are associated with a cough reflex, but we're not testing that clinically. Our last two cranial nerves are cranial nerves 11 and 12, and these are two purely motor cranial nerves that innervate a variety of specialized skeletal muscles. The accessory nerve, we know, is really a misplaced cervical spinal nerve, and basically its motor fibers are innervating the sternocleidomastoid and the trapezius on a corresponding side. Acting together, the sternocleidomastoids allow you to flex your head and neck, and the trapezius muscle is not a muscle that's acting cranially, but it's a muscle that acts entirely on the upper limb by allowing you to elevate and rotate your scapula, which is a necessary adjunct function when you are abducting an arm on a corresponding side. So, classic test of an accessory nerve is to ask the patient to elevate their scapula against resistance. And classically, when a patient has an accessory nerve lesion, there will be a shoulder droop on the corresponding side of the lesion. And if the lesion is complete, where it also affects the motor fibers of the accessory nerve that are going to the sternocleidomastoid, the patient will have a weakness turning their chin to the opposite side. Finally, last of the cranial nerves is hypoglossal. It too is a purely motor cranial nerve. It serves all of the tongue muscles except for the palatal-glossus, and allows us to elevate and depress the tongue, protrude and retrude the tongue, respectively. And certainly when I have a hypoglossal nerve weakness, it's going to affect those glossus muscles. And the classic way to test for hypoglossal nerve integrity is to ask the patient to protrude their tongue by utilizing the genioglossus muscles. And the other point to be made here is that when there is a hypoglossal nerve lesion, the tongue will deviate on protrusion toward the side of the lesion.